Okay, let's unpack this. The news recently broke that the piano man himself, Billy Joel, has canceled all his upcoming stadium shows.
Yeah, big news for music fans.
Absolutely. But what really caught our attention, and yours probably too, is the reason they gave. A diagnosis of normal pressure hydrocephalus, NPH.
That's right. His team put out a statement detailing how performing was actually making the condition worse.
Affecting his hearing, vision, balance. Sounds serious.
Definitely. And he's focusing on recovery now, physical therapy. It really puts a spotlight on a condition that, honestly, a lot of people haven't heard of.
Or maybe they've heard the symptoms but not the name.
Exactly. And it might be more common than we think.
Which is why we're doing this deep dive today. We've gathered a bunch of sources on normal pressure hydrocephalus.
Yep.
And our goal here is to really break it down. What is it? Why does it happen? Who gets it? What does it look like? How do doctors figure it out?
And crucially, what can actually be done about it? We want to pull out the key takeaways, cut through the jargon.
Right. And maybe the most important point right off the bat
Is that NPH is potentially reversible. That's huge.
Right.
Because the symptoms, well, they often get brushed off.
Like just getting older.
Yeah, or mistaken for something untreatable like Alzheimer's or Parkinson's disease. So just knowing NPH exists is the first step.
Okay, so let's start right there. Normal pressure hydrocephalus. It sounds like a bit of an oxymoron, doesn't it?
It really does. Hydrocephalus waterhead basically means extra cerebrospinal fluid, CSF, building up in the brain's ventricles, those fluid cavities.
Okay.
And in NPH, those ventricles are definitely bigger than they should be, pathologically enlarged. But
the pressure is normal.
well, when they measure it, usually with a spinal tap, a lumbar puncture, the opening pressure often reads in the normal range, at least at that specific moment.
So the system's backed up, the ventricles are full, but the pressure gauge looks okay. How does that work?
It's like a plumbing problem, but maybe downstream. Think of CSF flow. Made in the ventricles, flows out, circulates around the brain and spinal cord, then gets absorbed back into the blood.
Right.
NPH is what's called communicating hydrocephalus. The fluid can get out of the ventricles. The blockage isn't inside the ventricles themselves.
Oh, okay. So it's not like a dam right in the ventricle pipes.
Exactly. That would be obstructive hydrocephalus.
Mm-hmm.
In NPH, the problem seems to be further along, like with the absorption process, or somewhere in that space outside the ventricles.
So like the drain is clogged further down, slowing everything up, even if the immediate pressure reading isn't sky high.
That's a good way to think about it. And the critical point is sometimes that clog can be bypassed or fixed.
Which is why nailing this diagnosis is so important.
Absolutely critical.
So who usually gets this? Is it an older person's condition?
Mostly, yes. There is a type called secondary NPH, which can happen at any age, usually after something like bleeding in the brain or meningitis, something that scars up those absorption pathways. But the more common kind, the one where we don't know the exact cause, that's idiopathic NPH that really hits older adults.
How common are we talking?
Well, the numbers vary a bit in studies, but prevalence definitely climbs after age 60. Some estimates go as high as maybe 6% of people over 80.
Wow, 6%. That's not insignificant.
Not at all. And it seems to hit men and women pretty equally. Overall prevalence might be somewhere like 10 to 20 people per 100,000. So definitely not rare in the older population.
Which makes understanding it even more vital. So the big question for the idiopathic kind, why? Why does it happen if there wasn't a clear injury or infection?
Yeah, that's the million-dollar question, and there's no single answer, unfortunately. It's likely a mix of things.
Like what? What are the theories?
Well, one idea is it might be a sort of late-onset version of something that was maybe subtly present from birth, possibly linked to slightly larger head size.
Interesting.
Another angle is factors that might stress the CSF system over time. Things like chronic high blood pressure, maybe sleep apnea, even heart or lung issues.
So other health problems could contribute.
Seems likely. There's actually a really strong link emerging between idiopathic NPH and cerebrovascular disease.
Meaning problems with blood vessels in the brain.
Exactly. Hypertension, other risk factors for stroke, the kind of white matter changes you see on scans from small vessel damage, these are all strongly associated with NPH.
Mm-hmm.
One source we looked at suggested maybe almost a quarter of NPH cases could be related to these vascular risk factors. The idea is that poor blood vessel health might somehow interfere with CSF dynamics.
That's fascinating. Linking fluid flow to blood flow issues. What else?
There are theories about the absorption mechanism itself being faulty. Some autopsy studies show thickening in the membranes where CSF gets absorbed.
Okay, so the drain itself might be physically impaired.
Possibly. Another theory involves back pressure from the veins draining the brain, maybe issues with valves in the neck veins.
And you mentioned overlap with conditions like Alzheimer's. How does that fit in?
Yeah, that complicates things. Alzheimer's also causes brain shrinkage, which makes the ventricles look bigger. That's called hydrocephalus ex vacuo.
Right. Water on the brain because the brain shrunk away.
Exactly. But in NPH, the ventricles are enlarged out of proportion to that surface shrinkage. That's a key distinction on imaging.
But can someone have both?
Unfortunately, yes.
Mm.
Some people have what's called dual pathology, both NPH and underlying Alzheimer's changes. And if there's significant Alzheimer's pathology, the NPH treatment might not work as well.
And genetics. You mentioned that too.
Yeah, there's growing evidence. We're seeing it run in some families. And researchers are starting to identify specific gene mutations. So it's probably, a mix of genetic susceptibility, vascular health, maybe other factors we don't fully understand yet.
So a complex picture for the why. But the end result is these enlarged ventricles, even if the pressure isn't always high, seem to be pressing on the surrounding brain tissue.
That's the prevailing theory. Even if a spot check shows normal pressure, there might be fluctuations, or just a sustained subtle pressure effect on the white matter tracts right around the ventricles.
And that pressure is what causes the symptoms.
It's believed so. That pressure effect on those specific pathways, particularly connecting to the frontal lobes, is thought to lead to that classic symptom pattern.
Okay, let's talk about that pattern, the classic triad. The part people might recognize, even if they mislabel it.
Right. The three cardinal signs are difficulty walking, gait disturbance, cognitive problems, and urinary incontinence.
The old mnemonic. Wet, wobbly, and wacky.
Yeah, that's the one people remember, though clinicians prefer slightly more formal terms.
Fair enough. And you stressed earlier, the gait, the wobbly part is absolutely key.
Crucial. Gait problems must be the main issue, or maybe the only issue, right at the beginning. If someone starts only with memory loss or incontinence, it's very unlikely to be NPH.
Okay, so the walking has to be the dominant feature, at least initially. Describe that walk. What does the NPH gait actually look like?
It's typically slow, kind of shuffling, with really small steps. People often walk with their feet wide apart, a wide base, trying to stay stable.
Like they're afraid of falling.
Exactly. And turning is especially hard. They might take lots of tiny steps to pivot, and that's often when they lose balance. You hear terms like magnetic gait or glue-footed, like their feet are stuck to the floor.
Right.
The core features are that slow, wide-based shuffling pattern with difficulty turning.
How is that different from, say, Parkinson's disease? People associate shuffling with Parkinson's too.
Good question, because they can look similar at first glance. But a Parkinson's gait is often narrower, and sometimes people with Parkinson's can improve their walking with cues, like stepping over lines on the floor. Plus, Parkinson's usually comes with other signs: tremor, stiffness, maybe slowness of movement in the arms, less facial expression, things you typically don't see prominently in NPH. NPH really seems to affect the legs much more than the upper body initially.
Got it. So distinct features, even if both involve difficulty walking? What about the cognitive side, the wacky part?
This usually comes on later, months or years after the gait problems start. It's typically what we call a frontal subcortical pattern, meaning it affects those executive functions managed by the frontal lobes and their connections. So things like psychomotor slowing, just thinking and moving slower, trouble with attention, concentration, difficulty planning, organizing, solving problems, and often apathy, kind of a lack of motivation.
So less like the classic memory loss of Alzheimer's initially.
Generally, yes.
I mean,
Things like severe language problems or trouble with learned motor skills, like using tools, those aren't usually early features in NPH like they can be in Alzheimer's. Simple memory tests might even seem okay initially. You often need more detailed neuropsych testing to pick up these frontal deficits.
interesting. And the source mentioned something about naming difficulties.
Yeah, one finding was that significant trouble naming objects might actually predict a poorer response to treatment. An interesting observation.
Okay. And the final piece of the triad. The wet part, urinary issues.
Often starts as urinary urgency, just that sudden, gotta go right now feeling, frequently.
And maybe hard to get there in time because of the walking problems.
Exactly. The gait disorder definitely contributes. Later on, it can progress to actual incontinence. Sometimes reflecting that frontal lobe issue again, there might be a lack of concern about it.
So that specific combination, wobbly first, then wacky and wet later. What symptoms would make you think it's not NPH?
Generally, you don't see signs of globally high brain pressure. So no severe headaches, nausea, vomiting, vision loss, or papilledema swelling of the optic nerve. That normal pressure reading is key.
Right.
And while the CSF protein might be slightly elevated sometimes in idiopathic NPH, finding lots of white blood cells in the CSF would point towards infection or inflammation, not typical NPH.
Okay, so we know what it looks like, but as you said, these symptoms overlap with so many things in older adults. How do doctors actually nail the diagnosis and figure out if treatment, like a shunt, is likely to help?
It's really a step-by-step process. First, ruling out everything else. A really careful history and exam are needed to exclude other causes for the gait issues, the cognitive changes, the urinary problems.
Like what kind of things?
Oh, spinal problems like stenosis, peripheral neuropathy, inner ear issues causing balance problems, arthritis, side effects from medications, even simple things like a urinary tract infection or prostate issues in men, pelvic floor problems in women. Lots to consider.
Makes sense. Got to rule out the common stuff first, then imaging.
Absolutely essential. Brain imaging, ideally an MRI, but CT can screen. You're looking for those enlarged ventricles we talked about.
But the key is disproportionately enlarged.
Right. Exactly. Enlarged compared to the amount of space or sulci on the surface of the brain. If both the ventricles and the surface spaces look equally big and wide, that's more likely just age-related atrophy or hydrocephalus ex vacuo from something like Alzheimer's.
How do they measure that disproportion?
Yeah.
Is there a specific way?
There are measurements, like the Evans index, basically comparing the width of the front part of the ventricles to the width of the skull. A ratio over 0.31 is suggestive. But increasingly, doctors look for a specific pattern on the MRI.
Is that the DESH thing you mentioned earlier?
Yes. DESH, disproportionately enlarged subarachnoid space hydrocephalus. Quite a mouthful.
It is, but it sounds important.
It really is. DESH describes a specific look. Big ventricles, yes, but tight spaces for fluid over the very top and midline of the brain, combined with wider spaces lower down, like in the Sylvian fissures, and maybe some dilated grooves or sulci that look trapped without the brain tissue around them looking shrunken.
Okay, so it's a whole constellation of findings, not just big ventricles.
Correct. And seeing that DESH pattern is strongly linked to idiopathic NPH and, crucially, predicts a better chance of responding well to shunt surgery.
That's a really useful imaging sign then. More useful than just ventricle size alone.
Much more suggestive, yes. It helps differentiate NPH. And speaking of imaging, those white matter changes, those bright spots often seen on MRI scans in older adults.
Yeah, common finding.
They're common in NPH too. It's hard to know if it's from the pressure or just underlying small vessel disease. Very extensive white matter damage might mean a slightly less good outcome after surgery, but the evidence is a bit mixed. It's not as strong a predictor as DESH or the TAP test response.
Okay, so imaging, especially with DESH, points strongly towards NPH. But surgery is a big step. You need more certainty, right? How do you predict who will actually get better with a shunt?
Right. This is where the confirmatory tests come in. Basically, trying to see if temporarily removing some CSF improves the symptoms. It helps select patients for surgery. No single test is perfect, but they're really important.
What's the main test people hear about?
Probably the high-volume lumbar puncture, often called the TAP test. It's the simplest.
That's right.
You do a spinal tap and remove a decent amount of CSF, maybe 30 to 50 milliliters. Then you carefully assess the patient, especially their walking, right before and then shortly after, say 30 to 60 minutes later.
What are you looking for?
Objective changes, walking speed, how long their steps are, how smoothly they turn. Videotaping before and after is really helpful to catch subtle improvements. And you also ask the patient and their family if they notice any difference, maybe even over the next day or two.
How reliable is that test if they get better after the tap?
If there's a clear, objective improvement in gait after the TAP test, the positive predictive value is excellent, meaning they have a very high chance, maybe 90% or even higher, of benefiting from a shunt.
Okay, that's pretty good.
Right.
But what if they don't get better after the tap?
That's the limitation. The negative predictive value isn't as strong, maybe only 30–50%. So if someone doesn't improve right after a single tap, it doesn't completely rule out that they might still benefit from continuous drainage, like with a shunt.
So is there a test that drains fluid for longer?
Yes, that's called external lumbar drainage, or ELD. It's more involved, requires staying in the hospital.
How does that work?
A temporary catheter is placed in the lower back, and CSF is drained continuously, maybe 5–10 milliliters per hour for several days, usually 2 to 7 days. You're looking for clinical improvement over that sustained period.
Does that predict shunt response better?
The studies are a bit mixed, honestly. Some analyses suggest it can be quite predictive, maybe better than a single tap for those who don't respond initially, but it's more invasive and carries slightly higher risks like infection or bleeding than a one-time tap.
Okay, so doctors weigh the clinical picture, the imaging, especially DESH, and the results of these tap or drainage tests to decide about treatment.
Exactly, it's putting all those pieces together.
And the main treatment is surgery, putting in a shunt.
That's right. Usually a ventriculoperitoneal shunt, or VP shunt. It's basically a tube with a valve that drains the excess CSF from a ventricle in the brain, runs under the skin, down into the abdomen, the peritoneal cavity, where the fluid just gets absorbed by the body.
It sounds like choosing the right patient for that surgery is absolutely critical.
It is paramount. It's a very individualized decision.
What makes someone a really good candidate?
Generally, someone with the classic symptoms where gait problems came first and are the biggest issue. Someone whose symptoms haven't been going on for too long, maybe less than 6 months, is often better. Favorable imaging, like that DESH pattern. And, of course, a clear positive response to the TAP test or an ELD trial.
Secondary causes, too.
Yes, if there's a known prior cause, like a hemorrhage, they often respond well, too.
And conversely, what are the signs that maybe someone won't benefit as much from a shunt?
Things that raise red flags include dementia being the first or most severe symptom, or if the dementia has been present for a long time, say over 2 years. If the gait problems only showed up after the person already had significant dementia. Also, extensive white matter disease on the scan, or clear signs of significant brain atrophy, especially in areas like the medial temporal lobes, which suggests underlying Alzheimer's.
So if there's already significant, potentially irreversible brain damage from another cause, just fixing the fluid flow might not help much.
Precisely. But again, it's not always black and white. You have to weigh everything. One unfavorable sign doesn't automatically rule someone out.
Okay, so for those carefully selected patients, how well does the shunt work? What are the success rates?
The sources suggest that for appropriately chosen patients, somewhere between half and maybe even 2/3 can expect a real sustained improvement.
That's pretty significant.
It is, and encouragingly, the data shows that outcomes have gotten better over time and complication rates have come down, probably due to better patient selection and improvements in surgical techniques and the shunts themselves.
What kind of improvements do people see most often?
The biggest and most reliable improvement is usually in walking. Gait often gets significantly better, faster, more stable steps.
What about thinking and bladder control?
Those can improve too, but maybe less dramatically or less consistently than the gait. But improvements there can still make a huge difference in quality of life.
But it is surgery. There are risks involved, right?
Oh, absolutely. It's brain surgery, even if minimally invasive these days. Complications can happen. Some reviews estimate around 38% of patients might experience some kind of complication.
38%. That sounds high.
It includes a range of things, some minor. Serious permanent problems or death are much rarer, maybe around 6%. But needing another operation, a shunt revision, because the first one failed or caused a problem, that's more common, perhaps around 22%.
Wow. What are the most common complications people should be aware of?
One of the big ones, especially early on, is overdrainage. The shunt works too well, removes too much CSF.
What does that cause?
Can cause headaches. More seriously, it can lead to fluid collections or even blood clots forming on the surface of the brain's subdural effusions or hematomas.
That sounds dangerous.
Serious hematomas needing more surgery are relatively uncommon, less than 10%, but using programmable valves helps manage this.
Programmable valves.
Yeah, these are shunts where the doctor can adjust the pressure setting non-invasively from outside the body using a magnetic device. Studies show these are linked to fewer revisions and fewer subdural collections compared to the older fixed pressure valves.
Okay, that's a good development. What else can go wrong?
Infection is a serious risk, though less common now, maybe around 5% or less with antibiotic-coated catheters. An infection usually means the shunt has to come out, plus antibiotics. And then there's just the risk of the shunt malfunctioning over time, getting blocked or the valve failing. That's an enduring risk that might require adjustment or another surgery down the line.
So getting a shunt isn't a one-and-done thing necessarily. You need ongoing monitoring.
Absolutely. Regular follow-up is key. Interestingly, just looking at ventricle size on follow-up scans isn't always reliable for telling if the shunt is working. It's really about tracking the patient's symptoms.
Okay.
If there's a concern about malfunction, they might do specific imaging of the shunt tubing or maybe an ultrasound of the abdomen to check the end of the tube.
This all brings us back around to Billy Joel. His situation really puts NPH into the public eye. What's the bigger picture here for our listeners?
I think his story really highlights that NPH is a tangible, significant health issue that can affect anyone. And the symptoms, the walking, thinking, bladder issues, they deeply impact quality of life, independence.
And they're so easily mistaken for other things.
Exactly. Mistaken for just aging or for conditions people think are untreatable. That leads to delays in diagnosis.
And that delay could mean missing the chance for treatment to really work.
Precisely. The awareness that comes from a public figure sharing their diagnosis is incredibly valuable. It encourages people and doctors to think about NPH when they see these symptoms.
Right. It empowers people to ask, could it be NPH?
Yes. To understand that there's a diagnostic process involving imaging, maybe a tap test, that can identify people who might benefit from surgery.
And even with the risks of surgery for the right person, there's real hope for improvement.
There really is. When patients are selected carefully, shunting offers a genuine chance to improve walking significantly, regain mobility, and often get some cognitive and bladder function back too. Early diagnosis and proper selection are absolutely key.
It really makes you appreciate the brain's complexity, doesn't it? How a problem with fluid dynamics can show up as trouble walking, thinking, and controlling your bladder. It seems so disconnected at first glance.
It's a fantastic example of how interconnected everything is in the nervous system. And it makes you wonder,
What's that?
well, how many other symptoms that seem simple, maybe just a change in someone's gait, could actually be pointing towards a treatable underlying condition like NPH that's just being overlooked?
That is a really provocative thought, something to keep in mind.
Yeah.
So if we boil it all down, what's the most critical takeaway message for someone listening right now?
If you or someone you know is experiencing that combination of worsening gait, maybe some cognitive slowing or fuzziness, and urinary issues, especially urgency, don't just write it off as inevitable aging.
Ask the question.
Yes. Ask your doctor specifically about normal pressure hydrocephalus. Push for a proper evaluation, including brain imaging, and discuss whether a tap test might be appropriate. Recognizing NPH, getting properly assessed, and being considered for shunting if you're a good candidate, it can genuinely change lives.
That's a powerful message of hope, really. Thank you for breaking down such a complex condition for us.
My pleasure. It's definitely a condition more people should know about.
We certainly hope this deep dive has given you some valuable insights. Understanding NPH is crucial for recognizing it and making sure the right questions get asked. If you found this useful, please consider sharing it with someone. It might help maybe someone grappling with similar symptoms or caring for a loved one.
Yeah, spreading awareness is key.
And of course, for more deep dives into important and often complex topics like this, make sure you subscribe to the show. We'll be back soon with another one.